And this is the robotic system that my colleague basically developed now. There, as you can see there, if you look carefully, there are all different degrees of freedom, you call it. So you can actually target very, very well precisely where we want to. Okay, so that's the ultrasound probe, and you can just move it around and aim different places to deploy either the seeds or the biopsy needle and so forth. Okay, now let me just move on to interstitial interstitial lasers. This is what that is here, just say if this is the prostate, laser fibers go right into the prostate, and there's just a different view, and you see the fibers will then expand their energies and cover different areas like that. Again, we try to cover the whole prostate, but there are some limitations. Of course, there may be gaps that aren't treated, but this is the idea anyway for interstitial radiation. And this is how it looks in the operating room. That so-called template is very similar to the brachytherapy template. Again, we put the needles in the right different locations, different coordinates, like as I mentioned, C7 or whatever, and put the needles right into the prostate. This is a different concept using an agent that actually gets into the intravenous, injected into the person, and what happens is 2-cat is the name of just one agent. What it is a material that the so-called bacterial chlorophyll it sensitizes light. When it hits light, it sensitizes it. I don't speak Hebrew. Some of you may speak Hebrew, but in Hebrew, I guess 2-cat means burning bush. So basically, when it attracts light, it actually gets heat, and it can burn that particular area. So, and this is all may not mean a whole lot to most of us here. It's different wavelengths that you hit. So the idea is to target certain areas, and fortunately, tumors, cancers in particular, have more blood vessels going through them, and if you have blood vessels that have this material in it, it will attract the light better compared to normal tissue. So again, this looks like pretty chaotic, all the different fibers again through there, but this is so-called interstitial laser therapy. Now this is borrowed from my colleague John Trachtenberg at Princess Margaret. He's doing it slightly differently. He's using the MRI, doing magnetic resonance in the operating room, and targeting the prostate. He's doing so-called focal therapy now. Again, remember what I said earlier about focal therapy is still investigational, but we need some people to kind of do it, and on the forefront, Dr. Trachtenberg, certainly one of these individuals that are testing different things. He's using MRI to do this and targeting the prostate, and so there's a fiber goes in, and this is real time. This is the tumor that gets that one spot there. So he's just targeting one area, and it's causing damage. This is the MRI a bit later showing that area has been targeted and indeed has been destroyed. So, and you can monitor it, so-called thermography, meaning heat, kind of targeting and measuring heat, so you know body heat versus an area that doesn't get heated anymore, meaning if the tissue is dead, if there's no blood vessels, then it doesn't get heated. So that's how he's doing this as a very investigational treatment, as a focal treatment, and this is first line that Dr. Trachtenberg's doing. Somebody mentioned earlier about Cyberknife, that you may be getting a speaker to talk about that in the near future. So I just have one or two slides on this just to kind of complete the whole picture. What is Cyberknife? It basically is it calls, in technical terms, hypofractionated stereotactic body radiation. What that does is the ultrasound guiding, again using wires right into the prostate, and then they use strong local electric fields which cause intense bursts of energy right where you hit. So it's so-called electroporation is the other term for it, or nanoknife is another term. So there's a Cyberknife, there's a nanoknife, there are different areas that are being, this was actually from a group in Australia that's just started doing that. In the U.S., there's a website that tells you what clinical trials are going on. So this one, focal therapy for localized prostate cancer using electroporation. This is the Nanoknife. This study is not yet open for participation. So just being started, and this would be in the UK actually. This particular technology. So there are different technologies. Cyberknife. There's the so-called Nanoknife, electroporation, and so forth. So I'm just going to go on to this other technology that we've been doing, and this is called intraurethral or transurethral, meaning through the urethra. So here's a prostate. This is transurethral ultrasound ablation. Ultrasound, but it's not HIFU. HIFU is focused ultrasound, where all the energy is focused into one spot. Remember I showed that earlier. This is so-called planar, meaning the ultrasound waves are sent in one plane through this little through various openings, and then this whole probe rotates around at each place it goes around. It will send off energy and kill that part of the prostate. So this here, the person has to be inside the MRI magnet. The patient actually goes in, the probe is in already, and then we monitor it right in the next room outside of the MR, magnetic resonance image unit, and we can see this probe, and then it will go all the way around, and it heats it as it goes around. This is the middle of the urethra, the rectum is back there, so it sweeps around like that. So again, schematically, this is how it goes. And as I said, we monitored with heat sensing, and we know which part has been heated, which part has been treated, which part is deficient, needs to be treated, and so forth. So again, schematically, if it's got multiple areas, you can go around and sweep all around and hopefully take care of all the cancers. You could also theoretically think of doing focal therapy as well, but again, as I said, focal therapy at the moment is still considered investigational. So I should just make a disclosure that I'm, as one of the investigators for this particular technology for that one particular company, so I put in a question mark here. What they're saying is, will this particular procedure, the company is called Profound, company that's actually developed the technology initially in Sunnybrook, actually with a group at Sunnybrook in Toronto. They're saying, again, I don't claim anything here, this is their slide that says, will Profound be kind of, in terms of recovery time, in terms of treatment time, and so forth. Radiation is like several weeks, and surgery is here, again, several hours of operation, recovery time, and so forth. They're saying maybe it's down there. Now, I can tell you right now that the actual treatment is, even though the actual treatment is, they say, is less than an hour, the preparation is quite long. So in fact, at the moment, preparation, meaning putting the patient in the right spot and so forth, what I'll describe in a minute, to make sure it's in the right location within the MR unit, adjusting it. It's still basically a technology in development, but it probably has a role in with all these other things that I've described. So I guess this is where it was sent out, I think, as a news release at some point, that it performed the world's first, they call it, and then I got a couple of irate phone calls from a couple of groups in Israel, one group in France, there's somebody else that, well, we've done similar things. Well, in fact, they hadn't. They did something sort of similar, but not exactly what we did, so I guess we could still call it the first. So this is thermal ablation device with real-time magnetic resonance. And now at first, before we did it with patients that were treated, before the patients were treated, it was did some dog studies, and then the group at Sunnybrook did some patients. Dr. Klotz, my colleague and friend Laurie Klotz, actually did several patients with this machine, but why we're the first in this setting is that his patients right afterwards actually underwent prostate removal, radical prostatectomy. That was by design, they would do that just to see what the technology could actually do. So the results we obtained from from his studies, actually, of course, the patients knew that. They knew full well they were, they willingly participated in the program, but it gave very, very valuable information as to what the technology could actually do. And then what our study is designed to show is basically just a natural extension of what Dr. Plaza's study did. Of course, we want to just do the procedure and not have to have the prostate taken out. So that's what we're doing right now, and we're to see, and we'll be following these patients for years to come to see what their prostates will do, what the PSA will be doing, how the cancer is. We'll be doing biopsies and so forth. So again, this is the technology. We heat we cool the rectum to protect it. And I mentioned the dog studies. Some were bad, some were good, but this just showed how the dog studies were done, and the urethra. And then, of course, we sacrificed the dogs and to show what the damage was and whether we overshot, whether we undertreated, and so forth. So we learned a lot from the dog studies. And again, I mentioned the Sunnybrook studies from Dr. Chopra and Dr. Klotzer is one of the co-investigators in that. These were the ones that they took out the prostates afterwards and they mapped out. So that technology has continued. This was like 4 years ago now. Their initial publications, MR-guided initial results, mapping, and then, as I said, there were the initial feasibility studies showing whether it was actually possible or feasible to do it. And yes, it was feasible. So now we're into the next phase, and this is the patients actually are keeping the prostates for now. So how that's done is we have to position the device, and then the patient gets transferred into the magnetic unit. And then we take more pictures and really plan it in a very detailed manner. We're very meticulous, exactly how far the probe goes and so forth. Because the margin of error is relatively small. We obviously don't want to over-treat or under-target. Oops, sorry. And then the delivery of treatment, and all this time we're actually monitoring temperatures, different colors. As the color changes, we know that area has been treated, and as it sweeps around, we know. Now again, remember, this is only one plane. This is to show different planes. Like the prostate is a three-dimensional organ, so there'll be 10 of these slices all stacked up, and we can actually access each of those to see which part is being treated and where. And then we do afterwards, verification with another MR to see. The idea is to not have any more so-called perfusion or blood going through it, meaning that the area has been killed, the cancer has been killed. So there's just more pictures to show you. Again, this is the side view, called transverse view, and this is sagittal, meaning from the side. As you can see, the body, the person's front is over here, the back's over there. There's a tailbone. Here's a rectum. We put a cooling device in the rectum, and here's the penis with the urethra. This thing goes in. Here is the prostate, and there are several of these treatment ports that sends out the energy. So this tells us exactly where the location is. You can see this is actually pretty good details, even on the screen like this. The actual pictures on the actual machine actually is very, very detailed, and we can play with it. Plus, we can adjust it if need be. So that's actually takes the time in terms of localizing and making sure we're in the right spot. Again, example of this, the treatment, and we can go back to different areas and show. So far, 7 or 8 patients. The initial outcome is that it's safe. There's no, we hadn't had any major leakage, urine problems, or fistula. Remember I told you what fistula is. That's kind of connection between the rectum and the urethra, for example. But so far, no such problems. Some people have some mild blood in the urinary tract infection. So relatively minor side effects so far. And the patient's PSAs have dropped. This is before and this is after. So you see that PSAs have dropped. Again, I mentioned earlier, as one of the criticisms of some of the publications, I said, well, the follow-up is very short. Well, this is extremely short. So we certainly aren't taking this and claiming that this is, the answer to any, solutions to all prostate cancers. But this is, at least it's doing what we're expecting it to do. We're hoping that it will deliver what we want, which is minimal side effects, as a safe procedure that actually will help. Whether it completely kills all the cancer, only time will tell. Right now, what we're doing is we're targeting, because it's a safety study, we're actually targeting just slightly less than the whole prostate. That's what the Health Canada and FDA told us to do, actually, to not go as far out as we should. So we're leaving a little rim, but the idea is that the treatment actually, after a while, the heat will actually kill an extra 3 millimeters. So again, that's just further pictures of showing whether we can do, eventually maybe doing what we call whole gland, instead of whole gland, do the so-called focal therapy. So we're the first site. Another site actually in Germany just started, and they're just doing exactly the same thing as part of our trial. And this is one of the grateful patients there.